Okay, so we'll make a start. So welcome to our taster session. I'm Gary Royle. I'm professor at UCL, and I work in a field called oncology. Oncology is the treatment of cancer. And so what we're going to do today is give you a taste of what it's like to work in the medical physics parts of oncology. So if I share the screen and show you some slides. Okay. So today we're going to be talking about radiation physics in medicine. Radiation physics is a core component of medical physics, and many people that work in medical physics in the hospital work in X-ray or gamma ray in some form, so radiation. And so what we're going to be talking about is how does radiation energy help us to treat cancer? So I'll start off by telling you something about what the problems are in cancer therapy. And the first thing to note is a lot of people are affected. So since 1960, approximately half of people, which I imagine it's all of us on this call, will be diagnosed with cancer. And so all of our lives in some way will be affected by cancer at some stage. And if we look at the number currently, the number of new cancer cases per year in the UK, it is huge, a large number. And this number has been gradually increasing over time. The reason that more and more people get diagnosed with cancer is a few reasons. One, in that our average lifespan increases, and some cancers are more common in older age. Another is our lifestyle doesn't necessarily help. And a third one is we're actually better at diagnosing cancer now. So maybe there used to be a lot of cases, we just missed them. And so this actually translates to, unfortunately, a lot of deaths per year. So just over a quarter of patients currently die from cancer. And it depends on your access to good quality treatment and also diagnosis. So people in deprived areas and poorer countries are more affected. So it's diagnosed later or not at all, and the treatment available is less. If we look at the options that we have, so there's a few different ways that we can treat it. Most patients will have at least two of these options. And just to summarize, so immunotherapy and chemotherapy and hormone therapy, these are drug treatments. So biological and chemical treatments that will target the cancer. Surgery is the preferred option always. If you can completely remove it from the patient, then this is the best way. But often we can't do that because it will be difficult for the patient and have other effects. Today we're going to be focusing on radiotherapy, so the treatment of cancer using radiation. And roughly in the UK, between about 40 and 50% of cancer patients will have radiotherapy as part of their treatment, often combined with surgery and one of the drug therapies. In the future, we'd expect roughly 60% of patients to get radiation therapy as more technology and more equipment becomes available in the hospitals. So it's a successful treatment. So approximately 40% of the cancer patients that are cured had radiation. And it's actually very cost effective. The equipment itself, as we'll see, is expensive, but it's cheap to run. and the cost per patient is much, much cheaper than a drug therapy. So it's been around a long time, so over 100 years now. So back around about 1900, there was some studies that suggested that we could actually cure cancer. I think the headline is a little too optimistic, but it was the first suggestion that it could be used. And we see in this picture, it's changed a lot since then. We'll see some pictures of modern treatments. And the thing that's changed, so we see the patient here in the suit on the standard office chair, and the instrument just in front of him is an X-ray source. And it is just generally irradiating this patient. Now we are much more targeted, largely because we know where the cancer is in the patient. We know it actually quite precisely. Back then, we didn't really have a means of identifying where the cancer was. And so the patient was just broadly irradiated. Things have moved on a lot, but this is incredible early work. The thing also that has changed is our understanding of radiation. So for those that don't speak French, this says, this is talking about wool. And the little baby here is wearing a woolen jumper that's made of radioactive wool. And the message at the top says a healthy and sweet warmth from radiation. And there was this thinking, probably about 50 or 60 years ago, that radiation killed bugs and germs. And you could just have a gentle dose of radiation, and it would stop things like colds and viruses. We now know that that is actually true. It will kill those, but it will kill an awful lot else as well. So radiation is successful at killing cells, but it will kill all cells. It partly discriminates, as we'll see, but it will kill a lot of cells in its path. So how does radiation kill cells? So there's a couple of different ways, but the most important thing is we're trying to damage the DNA. So I'm sure you all know that DNA is formed in this double helix structure seen on the left, and it will have chemicals that form the bonds between these, this double helix. And a photon or radiation can damage it in two ways. So in the top case, the X-ray hits an electron, which then breaks down the water molecule. Water, as you know, is everywhere in the body, and the water molecule will dissociate. It will separate chemically. And this leads to a little change of chemical events, which leads to heat and also fairly reactive parts of the water molecule, this OH dot, which is known as a free radical. And what that means, it's very attractive to electrons. And a heating effect and this attraction of electrons can damage the DNA structure. The one below, the X-ray will hit an electron and actually cause it to move. And because the X-ray has quite a lot of energy, it gives a lot of kinetic energy to the electron. And the electron will then bombard the DNA nucleus and cause a rupture. And so what that can mean, in some cases, not always, but in some cases, both of this double helix of their DNA will snap. It's possible that the cell recovers and repairs itself. Our body is remarkable at repairing itself. All day, every day, cells are constantly being damaged and repairing. But in many cases, it doesn't. And the cell will then go on to die. And so what we're trying to do with radiotherapy is kill cancer cells, but not kill healthy cells. So we want to preferentially target our cancer. And this is a model showing the DNA structure. And different types of radiation damage the DNA in different ways. So an X-ray will pass through quickly and cause a little bit of damage. As we see, it's separated some of these purple molecules. A heavy ion, so this is something like an element in the periodic table that's moving at speed. Because it's bigger and heavier, it will cause a lot of damage. It's the difference between like throwing a light ball and a heavy ball at an object. The heavy ball will cause more damage as it goes through. And there's different ways that a cell can actually die. There's several ways, but there's preferred ways. So this is a video of something called apoptosis, and we can see the cells just starting to break down. So the circles are individual cells, and over time, this is the cells dying by this mechanism of apoptosis. And this occurs within a few hours of the patient being irradiated. There's another mechanism called mitotic catastrophe. And mitotic comes from mitosis. And mitosis is the way that a cell forms another cell. So a single cell will separate in two by this mechanism of mitosis and form an exact replica of itself. Now, if it's received some radiation and the DNA has been damaged, then it won't be an exact replica itself. It'll be a partial replica. But there's a question has just come through. Will we receive a recording of the meeting? Yes, yeah, we're recording at the moment. So this, in mitosis, if the DNA has been damaged, then the cell won't be an exact replica, and it causes some problems when it tries to give birth to a second cell. And the daughter cells, as they're called, that results from this birth, will then be not good quality cells, and they'll just be gradually absorbed by the bloodstream, and chemicals within the body will just destroy them. So we have these two mechanisms where within a few hours we get cell death, and also later, over days, weeks, sometimes months, the tumor will slowly die. And so if we treat a patient, the tumor will shrink over time by these different mechanisms. There's other ways a cell can die, which we don't really want it to, because that can lead to other side effects. So something we try to do with radiation is to actually make them die in particular ways. And we can use drugs and other chemicals to make that happen. I'll say at this point, as we had a question, there's a Q&A button you'll see. If you have any questions, please do ask. Like it to be as interactive as possible, and post a message in the Q&A section, and I'll answer it live. So how do we actually cure? Okay, so a question has come in. So I'll read out the question. I wanted to ask, because the radiation treatment does not only target the tumor cells, but every cell on its way, since the division rate of cells decreases according to old age, doesn't it make the surviving rate of elders low in radiation therapy? It's a good question. And you're right in that the rate of cell division does slow down a little bit with age, but not so much that it makes a difference. The thing that's more important about the rate is different tissues within the body, different organs within the tissue. They grow at different rates. So bone and skin very, very slow growing, whereas other tissues, for example, parts of the brain, certain organs within the abdomen, that these are quite fast growing. And also, so the fastest we ever grow at any stage is in the first 3 months as an embryo, where they're so rapidly dividing. And so this is why women that are in the early stages of pregnancy, that they have to avoid radiation at all costs, because the cells are growing so rapidly. The faster the cell is growing, the more susceptible it is to radiation damage. So between old people and young people, there's no real difference in the effectiveness of radiation, but it does differ from cell to cell. A second question has come in. What mechanisms should we use in a brain cancer? That's a great question. And hopefully over the next few slides, where we have some pictures of brain cancers, we'll go through that. And I'll try to answer your question as we go. So on the image here, we see an MRI scan of the brain of a patient, somewhere just above the eye level. And here, highlighted, is a brain tumor. And what we're trying to do is target this tumor, but avoid everything else around it. And so what the oncologist does is draws an outline of the tumor and decides how much radiation they want to give to that part. And then there's other people, known as radiotherapy physicists, whose job it is to decide how to deliver that treatment. And they decide, how can we hit the tumor with this level of dose and avoid the rest of the brain as much as possible. And then it's the job of the radiographer or radiation therapist, as they're called, to deliver that treatment to the patient in the best way. And so what we have here is a plot that shows how many cells we're killing against radiation dose. And we see this S-shaped curve. And where if we look at the curve, it says as we increase the radiation dose, we're increasing more, we're killing more and more cells. And we separated out here tumor as the blue curve and normal healthy tissue surrounding the tumor as the red curve. In the ideal case, these two curves are quite separated. So if we were to say we want to kill all of the tumor cells, then we can work out how much radiation dose does that actually take. But in order to do it, we're also killing really a lot of our healthy tissue. And although we're destroying the tumor, we're also creating probably very difficult side effects for the patient. So what we do is we pick somewhere where the difference is as much as possible. We kill most of the tumor, but for the minimum amount of healthy tissue. So the question comes, don't you leave some tumor behind? If we gave a single treatment, we would, yes. But we actually deliver radiation therapy in many, many fractions over a period of weeks, typically 4 to 6 weeks. And you also try to target the tumor by firing the beam precisely at the tumor and trying to avoid the healthy tissue as much as possible. So gradually, over time, we can kill all of the tumor cells, but whilst allowing the healthy tissue to be spared or at least recover. If we're unlucky, then there's a lot of overlap between the tumor and the healthy tissue. And this is really just down to the biology as to what we get. A question has come in. Are there ways to separate these curves, new techniques? There are. And so what we try to do, as the questioner has said, we try to force these apart. And you can use chemicals to do this, and sort of, and the biology, or biotherapeutics, as they're called. And this is ways that we actually try to reduce the sensitivity of healthy tissue to radiation and increase the sensitivity of the tumor to radiation. And we saw a little earlier that of the cell death, the ways in which a cell can die. And you can actually make a cell more likely to die by giving it certain chemicals. And so if we give the tumor these chemicals, then it increases its likelihood of dying. And it doesn't need so much to just push it over the edge a little bit. So at the moment, it's not so commonly used, as it's still something that that we're all researching. But techniques are starting to come in at the moment that help us to do that. So how do we deliver the radiation? So there's a couple of different ways. One is a technique called brachytherapy, where you actually insert the radioactive source into the tumor itself. And so we see the machine here, that the white machine that's glowing in the center of the picture, it has a blue cable coming out the end. And within this white machine, there are radioactive pellets, and they get pushed along this blue cable. And the blue cable, when the patient is on the couch, the blue cable gets inserted in by needle into the patient, into the center of the tumor. And then these radioactive pellets are left there for some time. Nowadays, these radioactive pellets are actually very, very strong, very intense. And so it's not so long that they're left there. In the old days, they were quite weak, and the patient could be there for days. It was a difficult treatment. But now it's much, much quicker. And what this does, it delivers radiation just to the tumor. Only you put them in the center of the tumor, and it doesn't hit anything else. It's a great technique, and it's good for tumors that you can easily get to with a needle. So something quite near the surface. If it's something deep within the patient, then it's very difficult to do it this way. And so largely it's not done that way. We need a different technique, which we'll come on to. I've just seen another question in the Q&A. So if there were still some tumor cells left in the body, is there a way to avoid metastasis? So for those of you that are not familiar, sort of metastasis is where the original tumor, the primary tumor, it has a way of growing quite aggressively, and it will send off cells, so cancerous cells, through the lymphatic system, through the blood system, through various pathways into other parts of the body. And these cells will travel through, locate somewhere, and if it's an environment conducive to growth in a different organ, they will form a new cancer, which is a metastasis. And this is currently one of the biggest problems we face in oncology: how to treat patients that have metastasized. The way to avoid it is that you treat the patient, you diagnose them early and you treat them early before it's had a chance to spread outside. Once it's spread outside, then again, you have a short window where you only have maybe 2, 3, 4 metastases in other organs within the patient. And then you can treat them all as individual tumors. in certain forms of cancer, they can spread a lot and spread very, very quickly. So we see this in something like lung cancer. They metastasize rapidly and quite widespread. And currently, when the patient has widespread metastatic disease, so multiple lesions in different places, it's actually very difficult to treat the patient at that stage. And our current knowledge, it means we can't help too many patients when they get to that stage. So we have to treat them before that. And so diagnose early, treat early is the solution. And a question comes up, a more technical question. What techniques do radiotherapists use when they are faced with craniospinal metastasis in children, both before or during their growth spurts? It's a great question. And treatment of children is slightly different in that you refer to the key point, growth spurts. So when we were talking earlier about the ways in which cells grow, mitosis, then the faster the cell is growing, the more sensitive it is to radiation. And so in children, cells grow at a faster rate, obviously, than in adults. And especially at the younger the child, the faster it's growing. Yeah. And then we need to be very careful with the radiation that we give to a child in those early years, because it can lead to effects in later life, and that it can increase their chances of developing a cancer in later life, or it can prevent certain organs from functioning correctly. It can prevent the muscle tissue, for example, or the bones from growing as they should. And so the patient will have, side effects as a result of their treatment. Craniospinal metastases. So cranio meaning the head, the surface of the brain, and spinal largely refers to the spinal cord in this case. And there are some tumors that will spread along this path. So if a brain tumor spreads metastatically, then it can pass along the surface of the skull and down through the spinal cord. These patients receive radiation to the full surface of the skull and to the full spinal cord. And the technique that we'll use for this, a preferred technique, is a technique known as proton therapy. Protons are the radiation form instead of X-ray, and we'll see in a few minutes how protons work and the benefits that they have for these children. And the basic answer is that with proton therapy, you can target just the surface of the brain and the spinal cord, whilst minimizing damage to the surrounding organs. You can actually treat the surface of the brain without hitting the brain itself, and you can actually treat the spinal cord without hitting the lungs, the heart, the liver, and all of the other organs that are near the spinal cord in a child. Because what we're trying to do in answer to your question is hit the cancer and not the healthy tissue, because the healthy tissue, particularly in children, will cause difficult side effects in later life. So coming back to the techniques, so we can implant a radioactive seed directly into the tumor. The most common way we do it is by X-ray. So we have a beam external to the patient and we fire a shaped beam at them. So this is an instrument known as a linear accelerator, where the blue beam is electrons. So we accelerate electrons to roughly the third of the speed of light, and then we convert them to X-rays, shown in orange here, and then we shape the X-ray beam to match the view of the tumor from where the X-ray beam is pointing. And as the X-ray machine, this linear accelerator, rotates around the patient, the shape of the beam will change shape according to what the tumor looks like from that view. So this is what's known as a conformal treatment, where we try to conform the dose map to the shape of the tumor as much as possible. Proton therapy. So proton uses, well, as it's obvious, protons instead of X-ray, and it uses a narrow beam, so maybe 2 or 3 millimeter diameter beam, and it will rapidly scan, much quicker than this, rapidly scan the tumor. And so if we go just, we think about this, so if I try to play it again. So the thing that differentiates protons with X-rays is that the proton beam will stop where you want it to stop. So we can actually paint a layer with the most intense part of the proton beam is at the end of its path. And there's no radiation dose beyond that point. And so we can actually paint in layers the tumor. And so what it means is we get no radiation beyond that point. So the question about treating craniospinal tumors is that something that's critical, a critical organ that's sensitive to radiation on the far side of the tumor, won't get damaged. And we do this with treatments, so ocular melanoma, which is a type of cancer that occurs on the back of the eye. So the back surface of the eyeball, we can get this tumor. And immediately at the back of the eyeball, as you know, is the optic nerve. The optic nerve is incredibly sensitive to radiation. A relatively low level of dose can damage the optic nerve and cause permanent blindness in a patient. So the question is, how do we treat the tumor and avoid the optic nerve? And the most successful way of doing it with proton therapy. So you fire the beam such that it stops just at the back of the eye and doesn't travel beyond the eye to hit the optic nerve and obviously all the brain tissue behind it. So at UCL and UCL Hospital, we have a proton therapy center that will be opening to treat its first patient a bit later this year in the summer. And the patients that we'll be treating, so roughly a quarter to a third of our patients will be children. To treat the types of disease that we were talking earlier, and because children are more susceptible to radiation, and we can actually improve their quality of life and reduce the chances of side effects using protons. Other techniques we use, coming back to an earlier question, is we will treat a lot of brain tumors. Brain tumors because the healthy tissue surrounding the tumor is quite critical and radiosensitive. So, for example, if there is a tumor at the base of the skull, so round about the place where the brain meets the spinal cord, then a problem that has long existed is how do we treat the brain tumor without damaging the spinal cord? And like the optic nerve, the spinal cord is sensitive to radiation dose, and we can cause permanent paralysis at that point. So it can be, in the past, it's been difficult to treat these tumors because how do you treat the tumor and cure the tumor without very considerable side effects to the patient? With proton therapy, it's now possible to do this. So you can hit the tumor and avoid the spinal cord. So let's see how it's improving over the years. So this is a curve that I've borrowed from Cancer Research UK. which looks at 10-year survival. So we measure the result of cancer treatment in terms of whether the patient is still alive at certain time points, so typically 1, 5, and 10 years, and also has the tumor progressed within that time. So this is largely so in the total survival. And we can see over the last 40 years how it's gradually improved. And this is purely as a result of cancer research. The only way we've improved it is by doing research to improve the quality of treatment. And for some reason, we see that women always fare better than men, and continually do. And let me show you this plot. So this is another plot I've borrowed from Cancer Research UK that says how the size of the purple arrow says how much improvement we've seen for this particular tumour. And going from left to right, it's from 0 survival over 10 years to 100% survival over 10 years. And you can see something like prostate cancer, the third one down, has a long arrow. Over a period of 40 years, it's gone from 25% survival to over 80%. And what we try to do in cancer research at UCL is to lengthen these arrows. And so the ones that we focus in on primarily at the moment is the ones down the bottom. So the intestinal cancers, such as stomach, esophagus, sort of pancreas, so things that are part of the digestive system. These have very poor survival, and it's barely improved over years because they're very, very difficult to treat. And lung, which is the world's most common cancer, again, we see such small improvement in survival over the years. The reason for it is that lung cancer is most of the time caused by smoking, cigarette smoke, and cancers formed from cigarette smoke, they're remarkably resistant to the treatments that we have available at the moment. And so a huge amount of effort at UCL and worldwide goes into trying to improve survival for these patients. So the question comes, having looked at those plots, why do some tumours respond well, like prostate, and why do some tumours respond badly? And what does it mean if a tumour doesn't respond well to radiation? Largely, it means it comes back, it recurs. So we can destroy most of the cells, but we leave some behind. And so we see here, so glioblastoma is a very aggressive form of brain cancer, and ovarian cancer within the ovary. These have a very high percentage of recurrence. So we treat them, and then there's a very high chance that they will recur. And so the question comes, how do we modify this response? And so a big focus of our work in UCL medical physics and broader in UCL, across UCL as a whole, we work on something called radiation resistance. So how do we overcome the resistance from certain types of cancer to radiation? And so effectively, we're trying to do this. So we had a question earlier, are there ways to separate these curves? And so a lot of the work we do is trying to push them further apart, such that for a certain radiation dose, this vertical dotted line, we can be very effective in killing the tumor while sparing much of the healthy tissue. And so what can we learn from nature? nature is remarkable at throwing up questions. You know, we've survived this long as a species due to nature. And so I'll quote this one because it's interesting. So a tardigrade, this is a very small creature, tiny, you know, just a few millimeters in size. And you see it here on a leaf, giving it a sense of scale. So tiny little bug, but have this remarkable property that they have a damage suppressing protein that protects the DNA. And so we saw earlier that radiation kills cells by destroying the DNA. But these creatures have this protein associated to the DNA that protects it. And it stops it being damaged to the same extent. And these are remarkably resistant to radiation. And so this is one way we can start to see, well, how does nature do it? And what can we learn about how do we suppress radiation damage? And so what chemicals can we use to put into the healthy tissue, not the tumor? We don't want to, stop the tumor. We want to put it into the healthy tissue, because we've seen on our curves, our S-shaped dose response curves, that if we put in a lot of dose, we're guaranteed to kill all of the tumor. The problem comes, we're also killing a lot of healthy tissue. So can we protect the healthy tissue that's near the tumor? And so we can increase the dose that we give to the tumor. Many trials have proven that increasing the dose will be more effective in treating the cancer. But in a lot of cases, it increases the damage to the surrounding tissue, which can be critical. So we have to sit as a compromise. And so we want to use chemicals to help that compromise. And so what can we learn from cell biology? The concentration of oxygen within the tumor is important. So this plot shows surviving fractions. So what fraction of cells are alive as a function of dose. And we see two different forms where hypoxic means it's got a low concentration of oxygen within the cell. Aerobic means it's got a normal concentration of oxygen. And so what this tells us, that a certain amount of radiation dose, it doesn't kill that many hypoxic, so low concentration cells. So if a tumor has a low concentration of oxygen, it's very resistant to radiation. And to understand this, we need to look a little bit about how a cancer is formed. So a tumor can grow from the center and gradually push out. So cancerous cells form at a particular point in the body, and they will expand. They'll divide and grow. And what it does, it pushes everything else aside, including the blood vessels. So we see here in red, the blood vessels, and the tumor is pushing those blood vessels apart. And the blood is what carries oxygen to the tissue. And so in the center, we see what's called this necrotic core. This is effectively those cells, they die. They're starved of oxygen and nutrients. Immediately surrounding it is this hypoxic region, shown in purple, where the cells have got low concentration of oxygen. And they're therefore quite resistant to radiation compared to the normal ones where they have the blood flow. The second thing, what can we learn from history? So this plot on the right shows years after the atomic bomb that was dropped on Hiroshima at the end of the Second World War. And on the y-axis, excess cancer deaths. So cancer deaths beyond what we would typically see. And we can see that for many, many years after, 30 years after, we still have an excess of deaths as a result of the radiation. And so that tells us that radiation damage can stay within the body for some time. And so why have these patients, if they had radiation damage, why did it take so long for the cancer to affect them? And the reason for this is because the effect of the radiation can lie dormant. It can basically be in a sleeping state within the patient. And the answer to this is from stem cells. So stem cells are basically the fundamental building blocks of all cells. If you have a stem cell, it will just grow and become whatever organ it was destined to be. And there's a theory that there are cancer stem cells. And if you have one cancer stem cell, it will guarantee to grow into a tumor. And they're very resistant to radiation. And they can lie dormant. The way the cell biology means that these stem cells can just sleep for years, decades at times, and then something triggers them to wake up, and then they form a tumor, and it affects the patient. So imagine we have this figure where the yellow ball in the center is a cancer stem cell, and the red ones outside are just regular cancer cells that have been formed as a result. We irradiate it, but we kill the ones that are less resistant. The radio-resistant cancer stem cell, we haven't given enough radiation to kill it, and so it will come back. And so this is one of the key factors that causes tumor recurrence. And so what we're trying to do here at UCL is understand how cancer stem cells survive radiation exposure. And can we then modify the stem cell, convert it into a different type of cell, and make it less resistant to radiation? And then can we manipulate the immune system? So the immune system is remarkably good at killing disease within us. Can we use it to kill cancer? And immunotherapy does exactly this. We actually put chemicals within the patient to turn the immune system onto the cancer. And let me just tell you an interesting case. So there was a patient that had radiotherapy to the colon, so down deep within the abdomen. But they were treated, and they also had a tumor in the lung, so higher up in the chest. And the radiation was found to have treated the tumor in the lung also, even though it wasn't targeted. So this is the patient. So this is up in the lung. So the lung tumor is shown on the left here. And 2 months after treatment, it had shrunk quite significantly, even though that tumor site wasn't treated. And so our understanding is that the radiation to the colon triggered a chemical effect that had a knock-on effect that triggered the immune system into turning on the cancer. And so elsewhere in the body, it had a good therapeutic effect. And so this is something we're trying to understand. Can we actually make that happen? Can we use the radiation to trigger the immune system and therefore manipulate it to treat elsewhere? And then the final thing I'll say is, what happens if the tumor moves? So here we see, so in the bottom right corner, this grey splodge is a lung tumor in this patient, and you can see it's moving as the patient breathes. radiation treatment takes minutes. And so within minutes, the patient can't hold their breath for that period of time. So we're trying to hit a moving target. And so we're looking at ways within medical physics at UCL to try to track the tumor, see where it is at all time, and then move the beam just to target it. And then can we then see what happens to the patient over time? So this is an image through the bottom of the head. So you can see the lower jaw here at the top with the teeth. And what this is showing is how the dose changes over time. So this patient was X-ray imaged every day. Every day they're in a slightly different position, or they're sitting differently. But also the patient changes shape, changes weight. Treatment can last 6 weeks, 8 weeks. So they're likely to lose weight over that time. And so we want to see, can we predict how the patient's going to respond, and then make sure we deliver the optimum treatment every day. And finally, can we treat more and more patients? We said at the very start, a lot of patients would benefit from radiation therapy, and we have a lot of cancer patients. And can we extend it? And I just finish with a picture. So this is from a clinic in South Africa, where this lion actually had skin cancer on its nose, and it was being treated. And it's not uncommon to treat animals with radiation therapy to try to cure the cancer. You just hope in this case the anesthetics was good. So let me end at that point. And if you have, I see lots of questions. So I'll just spend the last few minutes answering the questions. So first question, which of the techniques, which of the radiation treatment techniques has the highest success rate? Obviously different ones are used for different situations, but is there one that has a significantly better chance of long-term survival? No, there isn't. Some are better at some things than others. We looked at proton therapy. Proton therapy is more successful at some cases. For example, in children, in brain cancers, if there's a case where a cancer is very close to a critical organ that's going to affect, quality of life, then proton therapy is the better one. But it's not better at most cancers. Probably about 70% of cancers, there's no benefits. X-ray therapies are just as successful. And things like brachytherapy, where we insert the source into the patient, it's good for things like skin cancers, fairly superficial ones. We get a better success rate. But broadly, there's no benefit. One isn't necessarily better than the other if we choose the best one for the job. The next question, why is the percentage of survival higher for women than for men? It's a good question. It's been consistently the case. There's a lot of theories as to why. Some cancers are more prevalent in men, more common in men than others. Ones that are, for example, lifestyle dependent. Then things like diet and alcohol intake and so on. This can increase the chance of cancer. And these are ones that have quite, poorer outcomes. And those are more common in men than in women. Also, willingness to follow the treatments. Again, some people suggest that from the evidence that women are more likely to follow the advice that they're given and follow the treatment slightly better. But it's a good question. Another question, for the cancers that may require TBI. Okay, so TBI is total body irradiation, where you irradiate the whole of the person. For example, bone marrow transplant required to treat leukemia. What considerations must be taken into account to reduce side effects? Great question. And it's something that is very challenging. So what you want to do is effectively sort of cleanse the bloodstream from using irradiation. So you're treating the whole of the patient. The larger the volume of the patient you're treating, the more critical it is. The things that you can do to reduce side effects is to give only the amount of radiation that's precisely needed, no more. Give as much as you need to give the desired effect, but that's it. And so there's some very careful calculations and very precise radiation delivery in order to make sure that you give no more than is the absolute minimum required to do it. And then a question. Okay, thank you for this talk. Can you tell me what degree should I apply for if I want to study this subject? Great question. So at UCL Medical Physics, we run a series of degree courses that incorporate radiotherapy. Zoe, who's online and managing it, I'm sure has plenty of information about the types of degree courses that we offer that you could do. Medical physics is a great choice because radiotherapy is a very technical subject. It's the most technical form of oncology, form of cancer treatment, because it uses physics to deliver the radiation beam to build the instrumentation and to direct the radiation to the treatment. Okay, and then a similar question. What kind of undergraduate, graduate degree would you say leads into a career in radiation resistance research? Is it an interdisciplinary area of research? The answer, yes, it's very interdisciplinary. Within the team that I lead here at UCL, we have people from all different backgrounds. So we have people with a background in medical physics. We have people with a background in medicine, in biology, in chemistry, in computer science, in engineering. So something like radiation resistance and radiation oncology sits at that interface between many, many different subjects. And you can approach it from different angles. Myself, I was originally, I studied maths and theoretical physics, which seems a long, long way from oncology. But there's a remarkable amount of overlap between it. And so we use those techniques and many others. The more things and the more ideas we can throw at a subject, the better. And again, Zoe will have plenty of information about the types of degree courses we have here in medical physics and also broader at UCL. So another great question, does treating cancer patient with radiation produce another type of cancer to the patient? The answer is it can do. One of the potential side effects from radiation therapy is generating a second cancer in the patient. And this can and does occur. And so what we try to do, if we target the cancer, give only the level of radiation that's needed, try to avoid the healthy tissue surrounding it as much as possible, then you can significantly reduce the type of, reduce the chance of a second cancer in the patient. and this is something that we are actively researching. So I realised I didn't turn my video on to answer your questions. So a couple more questions we have, and I see we're running out of time. What factors specific to the patient affect the duration of time between radiotherapy treatments and thus the length of the treatment? Yeah, another fantastic question. It's the biology of how the radiation interacts with the biology within the patient. If we irradiate both a tumour and healthy tissue by the same amount, largely because of the blood flow and the oxygenation, we find that healthy tissue responds better and quicker to radiation because it's been fed nutrients and it got the chance to breathe, whereas tumours often don't get that same extent. And so if we deliver a treatment every day, then from one day to the next, the healthy tissue will typically have recovered better than the cancerous tissue. And so this is one of the reasons why we do it a bit each day. Another reason is minimizing risk. If the patient moves or the beam missed the tumor, if we've given all in one go, then we've obviously have a real problem with the patient. We've missed the tumor and given a lot of radiation somewhere else. So we minimize risk by delivering it a little bit. And we're actually looking at this at the moment in quite a lot of detail, because the biology varies from cancer to cancer. And so there's certain brain cancers that would respond better if we change the frequency of the treatment. So actually gave it a few times per day rather than once per day. And there's other types of cancer that actually do better if we give a lot of radiation, but occasionally. So ideally, when in the future, we will be optimizing this per patient. At the moment, it's reasonably standard, that there's some variation, but not so much. But in the future, it will be different for different disease. And then the final question, or final couple of questions, how do I know the amount of radiation dose to apply to a cancer patient? This has been studied over many years by clinical trials. We know that a certain amount of radiation dose kills a cancer of this type. If we increase it a little bit, it creates more side effects. If we decrease it a little bit, we don't get so much cure. And this has been studied over many, many years through trial. We have the opportunity now to actually work out a bit more through the physics, through the biology, through the chemistry, and be a little bit more precise and deliver something known as a personalized treatment, where every cancer patient has an amount of radiation dose that's specifically calculated for them. And then the final question, what's the routine work of a medical physicist in a hospital? There's a long answer to that because it's very varied what they do. In the examples that I've given, a medical physics would be involved in every aspect of the treatment. They would be working out how to image the patient, where is the tumor, how to deliver the radiation beam to that precise spot of the tumor. Have we delivered it correctly? How do we improve the equipment, the delivery, the technology, the medicine, and how do we make sure that next time we learn from the previous patients and we can gradually improve over time. So the routine work is very broad. Just in radiotherapy, there's many different aspects, from imaging to instrumentation to technology to delivery to calculation to computing to working to improve each individual patient treatment. Okay, so we've come to the end of our questions, and I think we've possibly come to the end of our time. Zoe, if you're still there, what do we end at this point?
Thank you, Gary. Yeah, thanks everyone for your excellent questions. As Gary said, I've put some links for the degree-specific questions there in the answers and in the chat. So I hope you've seen those. And we'll be following up with a recorded version of this session in the next week or so. So you'll be able to find that online.
Okay, great. And thanks everyone for coming, and fantastic set of questions. I was worked hard by the level of the questions that was being asked here. So yeah, no, great. And thanks for your interest. Okay, so check out the messages in the chat, have a look at our website, and thanks for your interest. Okay, bye.